Division of Viral Hepatitis. Epidemiology and Prevention of Viral Hepatitis A to E, Hepatitis E virus. Slide 1, Title Slide. This slide set presents an overview of the clinical and epidemiologic features for viral hepatitis A, B, C, D, and E and prevention measures for these infections. More detailed information regarding the epidemiologic features and prevention measures can be found online at http://www.cdc.gov/mmwr/mmwr.html. For hepatitis A, read the MMWR, Prevention of Hepatitis A through Active or Passive Immunization. Recommendations of the Advisory Committee on Immunization Practices, Volume 48, No. RR 12:1, the 10th of January 1999. For hepatitis B, read the MMWR, Recommendations to Prevent Hepatitis B Virus Transmission, U.S., Volume 44, No. 30:574, the 8th of April 1995, updated. For hepatitis C, read the MMWR, Recommendations for Prevention and Control of Hepatitis C Virus, HCV, Infection and HCV-Related Chronic Disease, Volume 47, No. RR 19:1, the 16th of October 1998. Division of Viral Hepatitis. Geographic distribution of Hepatitis C. Outbreaks or confirmed infection in greater than 25% of sporadic non-ABC hepatitis. Slide 76, Geographic distribution of hepatitis C. Outbreaks of hepatitis C have occurred over a wide geographic area, primarily in developing countries with inadequate environmental sanitation. The reservoir of HIV in these areas is unknown. The occurrence of sporadic HIV infections in humans may maintain transmission during interepidemic periods, but a non-human reservoir for HIV is also possible. In the United States and other non-endemic areas, where outbreaks of hepatitis C have not been documented to occur, a low prevalence of anti-HIV, less than 2%, has been found in healthy populations. The source of infection for these persons is unknown. Note, the map of HIV infection generalizes available data and patterns may vary within countries. Epidemiologic features. Hepatitis C-. Epidemiologic features. Most outbreaks associated with fecally contaminated drinking water. Minimal person-to-person transmission. U.S. cases usually have history of travel to HIV endemic areas. 29. Incubation period, average 40 days, range 15 to 60 days. Hepatitis C, clinical features. Incubation period, average 40 days. Range 15 to 60 days. Case fatality rate, overall, 1% to 3% pregnant women, 15% to 25%. Illness severity, increased with age. Chronic sequelae, none identified. Slide 73, Hepatitis C, clinical features. The incubation period following exposure to HIV ranges from 15 to 60 days, mean, 40 days. Typical clinical signs and symptoms of acute hepatitis C are similar to those of other types of viral hepatitis and include abdominal pain, anorexia, dark urine, fever, hepatomegaly, jaundice, malaise, nausea, and vomiting. Other less common symptoms include arthralgia, diarrhea, pruritus, and urticarial rash. The period of infectivity following acute infection has not been determined, but virus excretion in stools has been demonstrated up to 14 days after illness onset. In most hepatitis C outbreaks, the highest rates of clinically evident disease have been in young to middle-aged adults. Lower disease rates in younger age groups may be the result of anecteric and/or subclinical HIV infection. No evidence of chronic infection has been detected in long-term follow-up of patients with hepatitis C. Hepatitis C virus infection. Typical serological course. IgG anti-HIV. Titer. Symptoms. ALT. IgM anti-HIV. Virus in stool. 1. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 weeks after exposure. Slide 74, Hepatitis C virus infection, typical serologic course. The typical serologic course following HIV infection has been characterized using experimental models of infection in non-human primates and human volunteer studies. In 2 human volunteer studies, liver enzyme elevations occurred 4 to 5 weeks after oral ingestion and persisted for 20 to 90 days. Virus excretion in stools occurred approximately 4 weeks after oral ingestion and persisted for about 2 weeks. Both IgM and IgG antibody to HIV, anti-HIV, are elicited following HIV infection. The titer of IgM anti-HIV declines rapidly during early convalescence. IgG anti-HIV persists and appears to provide at least short-term protection against disease. No serologic tests to diagnose HIV infection are commercially available in the United States. However, several diagnostic tests are available in research laboratories, including enzyme immunoassays and Western blot assays to detect IgM and IgG anti-HIV in serum, polymerase chain reaction tests to detect HIV RNA in serum and stool, and immunofluorescent antibody blocking assays to detect antibody to HIV antigen in serum and liver. Prevention and control measures for travelers to HIV endemic regions. Avoid drinking water and beverages with ice, of unknown purity, uncooked shellfish, and uncooked fruit/vegetables not peeled or prepared by traveler. IgG prepared from donors in Western countries does not prevent infection. Unknown efficacy of IgG prepared from donors in endemic areas. Future vaccine. 31, 31, 31.